I'm calling the meeting of the Hospital Authority Board to order. Reverend Stevenson can't be with us tonight. I learned relatively recently that I'd be running the meeting, so please bear with me. We'll start with the mission statement, and I would ask Dr. Hudson to read that for us.
Certainly. Good evening. The mission statement is to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice.
Thank you. And next, I'd like to introduce a new member of the board, Dr. Ari Nettles, who's is a clinical psychologist at Vanderbilt. Yes, well, you still are. You'll be practicing that in this room, I believe. Okay. Yeah. Okay. We also have a new board member who's been approved by the council, David Esquivel, and unable to be here tonight from a previous commitment. And I'd also like to introduce Dr. Keith Stokes. Dr. Stokes, could you stand? Keith is in family practice, but now in administrative medicine, and he is the new medical director over the medical staff here. And I think we have a couple of new administrative members as well, if you want to introduce.
I certainly do. Want to introduce our new quality director, Felicia Dennison. And do we have any other new? I think we already introduced our compliance officer, Ms. Christy Lewis.
Now, comptroller.
Where is he?
Oh, well.
Oh,
He's behind you.
You got your new controller here, Dr. Webb. Keith Moran.
there you go. We introduced Keith Moran, our new controller. And I think that's it.
Good. Thank you. Okay, conflict of interest. This is an opportunity for any member to let us know if they have a conflict with anything that's becoming before the board tonight. Anyone? No? Okay. Thank you. Public comment? Looks like we don't have any. And the minutes from our last meeting, which was 3 months ago, June 27, have been distributed. Do we have any additions or corrections to the minutes?
Move to approve.
Have a second?
Second.
Okay. Any discussion? All in favor, aye, please.
Aye.
Thank you. All opposed? Which brings us straight to the discussion of the report of the Bylaws Committee. The Bylaws Committee has been working on some bylaws changes for well over a year, and we've had some change in leadership, and we currently don't have a chairperson because Michelle Brown rotated off of the board. But I've spent some time this summer meeting with or discussing with Stacy and getting things, and I'm ready to present the report of the Bylaws Committee. But first, I would like to appoint at Reverend Stevenson's request myself as the chair of the Bylaws Committee, and in addition, our new board member, David Esquivel, assuming that he will accept that appointment. That has to be ratified by the board. So I would ask for a motion to approve those appointments.
Move to approve.
Any discussion? All in favor? All opposed? Thank you. So the bylaws and their changes have been distributed to you, and rather than go through everything, I want to mention a few highlights that are the main changes. A lot of the changes were just grammatical and to get us in compliance with other things that we're doing. But the first major one has to do with the makeup of the board members. And up until now, one of the three licensed physicians, it says, shall also have had special training, practice, and experience in the field of psychiatric medicine. So as the mayor looked for replacement for Dr. Burley, he found Dr. Nettles, who's not a psychiatrist, but equally qualified, we feel, to fill this role. So the Metro Council has already changed the, I guess it's a charter for the HAB to change it to say one of the members shall also have special training, practice, and experience in the field of psychiatric medicine or psychology. So we need, although the charter probably supersedes our bylaws, I would look for a motion to adjust the bylaws to include that wording.
So moved.
Okay. Any second? All right. Any discussion? All in favor? Aye. All opposed? Okay. That's your second welcome, Dr. Nettles, and you may now vote. Thank you. I don't know if any of you are following this, but on page 5, there is one change concerning closed sessions. As you know, during a meeting, a closed session can be asked for and voted upon. And it says Tennessee laws authorizes the board to convene an executive session closed to the public in 2 instances: to develop marketing strategies and to consider strategic plans. And a third has been added, consistent with what we need and do, is to review legal advice concerning pending or threatened litigation. So that is part of the overall proposal that is recommended by the Bylaws Committee. So I'm not asking for a motion for that, but are there any questions about that? Okay. Next is on page 6, section 8, attendance and removal from office. And the Bylaws Committee under Michelle Brown has brought this forward. And the current one reads, members of the board may be removed in the same manner as other board or commission members of the Metro government of Nashville and Davidson County. And that method is, we can't remove somebody from the board. It would be Metro Council. So that's a long-standing part of our bylaws. As all of you know, we've had some trouble transacting business even before this summer for failure to have a quorum. And what I'm about to read to you this came forth before we had the last 2 meetings canceled for lack of a quorum, because there have been other meetings when we actually had to call somebody back from home to get something important done. But the new wording to be added is, if a board member fails to attend more than 3 consecutive meetings, the board chair shall counsel the member to determine their ability to fulfill their duties. If a board member fails to attend at least 50% of regularly scheduled meetings in any 12-month period, the member may be recommended for removal. So that would be a recommendation to the mayor, and it says maybe. It does not say will be, and this is not retroactive. If this is enacted, it would start as soon as our bylaws changes took place. Now, since we've had the experience over the summer of having 2 meetings canceled for lack of a quorum, I would like to suggest the following change, that we say if a board member fails or indicates inability to attend more than 3 consecutive meetings, then the board chair shall counsel the member to determine their ability to fulfill their duties. Meaning if we don't have the meeting because several members couldn't come, then they would still be deemed to have missed those meetings for purposes of this section. And in the second sentence, likewise, if a board member fails to attend or indicates inability to attend at least 50% of regularly scheduled meetings in any 12-month period, the member may be recommended for removal. This is not directed at any particular person. This is directed at an effort for us to be able to conduct the business that we need to conduct for this board. As evidenced by today's agenda, we're way behind. We'll have a lot to catch up on, and we just want to codify in our bylaws the expectations of board members. So this addition, what you see in blue, if you're having the same kind of copy I have, the addition to Section 8 will be a part of the overall revisions to the bylaws. I would entertain a motion to inject the words "or indicates inability to attend" in those 2 places.
Chairman, can I ask for some clarification, just to be certain that I understand?
Yes, sir.
So if 2 meetings in a row are canceled because of an inability to get a quorum from some members who have indicated that they could not attend,
right,
but those members that could potentially attend, if they miss the 3rd meeting, that doesn't count against them?
No,
Okay, just wanted to be sure.
I would not.
Okay.
Good point. Any other? Yes.
Dr. Martin, I have a question too. So I know that you referenced that some of the additions are consistent with other boards, metro boards. Is this attendance section similar, or how does this compare to some of our peers?
I asked legal to look at the other boards and see if they could see any attendance expectations, and none were found. So we're creating this, and I don't know if the other boards have a problem like this or not, but.
Let me just speak to that since I've been on parks and airport. We don't normally have a quorum issue. So I don't know that this is the same issue that we face with this board, to be fair. So I think that in my opinion, the changes make sense since we have been having issues, and it does require a lot more time on the part of us who have to review and be part of these other contracts. Instead of having 3 contracts, we have 10 contracts to review and approve. And in all fairness to everybody's time, I think that this type of language makes sense, since we seem to have an issue with this.
I agree. I was just wondering if it was consistent, but I also
We
agree.
searched for that, but couldn't find it.
The language regarding the legal piece that you mentioned earlier is part of, I believe, the airports. Don't quote me on the bylaws, but I do know that we've gone into executive session specifically for legal purposes, so I would assume that the language is in those bylaws. So I think that might be what they're referencing.
Okay. So I would entertain a motion with again, the overall paragraph and clause will be a part of approval of all the bylaws changes. But I would entertain a motion to revise by adding those words "or indicates inability."
So moved.
Second.
All right, any discussion about that? All in favor?
Aye.
Any opposed? Okay, thank you. Next is on page 8 under Medical Staff Committee. So there's a medical staff committee required by the bylaws. Our medical staff committee has not been meeting, and it doesn't, it says it will convene as needed to review practitioner credentialing applications. Tonight, I'm proposing that we add to that, this committee will convene as needed to review practitioner credentialing applications in consultation with the chief medical officer. And the reason for that is that many times when the credentialing is presented here, we haven't had someone who could answer questions about, somebody would tell us about this new physician or their contingencies and so forth. And there's some proposals out there that we hadn't looked at about the medical staff committee, but I think that we need, when the credentialing is reported by a board member, I think we need that board member to have reviewed with the chief medical officer the new members coming in and so forth, so that answers can be made when questions are asked in the board meeting. So I would entertain a motion to include that phrase in consultation with the chief medical officer.
So moved.
Second.
Any discussion? All in favor? And that's really it. Otherwise, the recommendation of the bylaws committee is as submitted to you for review, and we've approved these 3 amendments to what has been proposed. This is a product of a lot of work over many months, mainly done by Michelle Brown and our attorney, Stacy. Is Stacy here? There she is. Thank you, Stacy. So Stacy, I think, can answer more questions than I, if you have them, about any changes that we're proposing in the bylaws. Are there any questions? All right, good. Well, I would entertain a motion for approval of the bylaws changes submitted.
So moved.
All right. Do I hear a second?
Second.
Okay. Any further discussion? All in favor? Aye. All opposed? None. And so these changes in bylaws are effective at this point. Thank you very much. Okay. New business, board resolution authorizing assumed corporate names. Christy Lewis, our Chief Compliance Officer.
This is a resolution by the board to formally adopt all of the names used by the hospital. Currently, we've included the pharmacy locations or the pharmacy area, which is a community pharmacy, the Metropolitan Hospital, which is the inpatient area of the pharmacy, as well as the Metro Center location. Then we have the Diagnostic Center, which includes the name or the trade name used for the Nashville Healthcare Diagnostic. And then lastly, the Nashville Healthcare Center, which is the clinic area. This helps us to formalize those names, get it on our listing within the business area or business search area within the Tennessee, or the Secretary of State with the Tennessee, and it just formally adopts that. So that is my request, and hope that the board can approve of this resolution.
Any discussion? Do I hear a motion for approval?
Move to approve.
Second? Second. All right. All in favor? All opposed? It passes.
Thank you.
Thank you very much. The next thing on the agenda is committee updates, and we've already dealt with that. I will say there's a proposal that the Bylaws Committee has not reviewed concerning some potential changes in committees that we will, the new Bylaws Committee will address. Hopefully we got a meeting scheduled before too long. I'm not sure where this proposal originated. Can you answer that, Stacy?
I do not know.
Okay. All right. Well, it has to do with really efficient discussion of compliance issues in appropriate setting is the main thing. But we will reconvene this committee and get back to you in the next couple of months on that.
Dr. Martin, can I add something really quick to that?
Yes.
I think I voiced that concern before, in that when we're identifying board members for participation in committees, it would be nice to, at a minimum, get kind of some buy-in. A lot of it's like, hey, you'd be good for this. You know, at a maximum, I would think something like a Clifton strengths of really aligning our core kind of strengths and, you know, where we excel into this. Because as we know, we're all, you know, volunteering our time. And I think it'd be most beneficial if we're aligning our time with things we have experience and expertise in it. You know what I mean? So I've voiced that a few times. I know I'm happy to fill in the gaps, and I feel like that's what I've been doing for the last 3 years. But it'd be nice to align some strengths with those committees to maximize effort and time.
I think it's a great suggestion, and Reverend Stevenson is on the line and has heard your suggestion, I believe. Okay, I'll call on Mr. Lesser for a report of the nominating committee. Oh, okay.
The nominating committee met a while back, and we have nominated the hospital board chair, vice chair, and secretary. So I guess we are going to do paper ballots. Is that right?
We are?
Okay. So the nomination for chair was Frank Stevenson. Are there any other nominations from the committee that we should add to this ballot? If not, we'll move to the vice chair, which the committee has nominated Dr. Raymond Martin. Is there anybody that would also like to be considered for vice chair? And then the secretary, the nominating committee nominated Christy Smith. Are you willing to serve in that capacity?
That was weird.
She's been vetted for that already.
Okay. Are there any other people that would like to nominate anyone else for that position? Do we need to vote on the nominations?
Well, I guess we need to accept the report of the nominating committee.
All right, move to accept.
Yeah, you've presented it, so I think we only need a second.
Second.
All right, all in favor? All opposed? Thank you. All right, you have ballots before you, and if you will, vote accordingly, either vote for or abstain, I guess. And this is not a secret ballot because it's a public meeting and this is all public, but Dr. Hudson will compile the results and announce to us. So while the ballots are being counted and recounted, oh, you have to read them. Okay, that's right. Go ahead. Go ahead. Yeah.
Okay, Dr. Hudson has agreed to keep the tallies as I read them aloud. We have to have 6 votes to declare a winner. So the votes of Dr. Miller: for Chair, Stevenson; Vice Chair, Martin; Secretary, Smith. The votes of Dr. Hudson: Stevenson, Chair; Martin, Vice Chair; Smith, Secretary. The vote of Dr. Martin: Stevenson, Chair; Martin, Vice Chair; Smith, Secretary. The vote of Smith: Stevenson, Chair; Martin, Vice Chair; Smith, Secretary. The vote of Fisher: Dr. Fisher voted Stevenson, Chair; Martin, Vice Chair; Christy Smith, Secretary. The vote of Dr. Nettles: Stevenson, Chair; Martin, Vice Chair; Smith, Secretary. The vote of Mr. Lesser: he's abstained from Chair; Martin, Vice Chair; Smith, Secretary. So we have a total of 6 for Stevenson for Chair, 7 for Martin for Vice Chair, and 7 for Christy Smith for Secretary.
So a majority of the entire board, not the board president, is required to elect officers, and 6 constitutes a majority. So these 3 are duly elected. And according to the bylaws, there will be another election, hopefully in June on time next year. Okay, now I've already made one mistake. I didn't, in the bylaws, something, and you've all read it, but something I didn't point out that is new has to do with contracting matters. And one thing it does is raise the threshold for our reviewing contracts from $50,000 to $100,000, and it's all in there. You've read it. You've all approved it, but it just kind of makes it more. It was always a question of, what do we have to review and what do we not have to review, and it outlines some contracts that the CFO can approve and that the CEO can approve an emergency, anything that needs to be done as long as it's ratified later at the next board meeting. So I should have asked for questions about that, but you all had it in the packet. So if there are any questions about that now, we can take them. I'm sorry that we've already accepted those changes, but I'll just give you that opportunity.
Sorry, is that per year per year contract?
Oh, yes. There is a limitation that anything that exceeds 3 years. Stacy?
Yes, that is correct. Regardless of the exceptions that outline. Oh, sorry. I rarely get. Okay, in answer to. Did I do it right? In answer to Christy's question, it's per year, and yes, and this is on page 10 of the, if you're looking on page 10 in the middle, but you'll also see that there is a requirement that any contract that has a 3-year or more term does require board approval, regardless of the carve-outs monetarily made.
Any other questions or discussion on this? Okay, thank you. I'm sorry for bringing that up late, but I thought it was important to do. Next is approval of contracts, and we have 9 contracts accumulated over the last 3 months. And I will say that the Finance Committee has met and gone over each of these contracts individually, presented by the person who knows the most about them, and approved all of them. However, Ms. Smith is going to give a capsule of each one of them, and you're free to ask questions before we vote.
All right, so I'll run through these contracts, and if anybody has any questions, feel free to stop me. I will rely on, obviously, my partners in crime, a lot of them with way more expertise in the subject matter than myself, but we thought for time purposes, we'd try to do it this way. So the first contract is the Southeastern Emergency Physicians. So this has to do with the service agreement that services the emergency room. It's the same group that's worked with our emergency room for a while. And all of these individuals are board certified and needed for this, our trauma level 3. Now, obviously, the no-wait emergency room, which is part of the benefit, obviously, of our emergency room, and has increased, obviously, the work and the type of need for these new physicians coming in. We're about 25% below market rate here, and they're basically asking for an increase of $40 per hour, which is the total of $372,855. Each of these individuals that are servicing our emergency room have a long tenure, over 10 years of employment here, and they've not had a rate increase since 2016. So just to start out, we've all discussed this in our financial meeting before. We have all unanimously agreed to and moved to approve this at the full board level. So any questions before I move? Okay.
Can I point out,
Yes.
Dr. Bullock is here
Yes.
with us. She's been here for 17 or 18 years, and I visited with her down there. There are a lot of people that have been here for several years that are loyal to the institution, and this is certainly time for this. Thank you.
Do we vote on each contract?
I think we need to.
Move to approve.
Is there a second? Sorry.
Go ahead. You do it. Is there a second? Any discussion? All in favor?
Aye.
All opposed? Thank you.
Next contract is the Pharmacy One Source Century 7 agreement. This is a surveillance application and infection prevention module. The contract's for 5 years at a cost of $35,502.11 per year with a 5% annual price increase every 5 years. This contract will really help out in the sepsis area, which is our quality area, and the interface will provide real-time adjustment with lab results for the pharmacy and able to really help in those numbers. So again, unanimously approved to move to full board. Any questions?
Every year for 5 years.
The total contract cost is $196,000.
You said every 5 years, but
I'm sorry.
every year
Yes,
for 5 years.
that's correct. So the cost is $35,502.11 per year, but the total contract cost over the agreement of 5 years is $196,171.58. Sorry.
Move to approve.
Do I hear a second? Any discussion? All in favor? Aye. All opposed? Passes. Thank you.
The next is a tenant building group agreement. This has to do with the heating and cooling piece for it's a HVAC piece for the cath lab. This did go out to bid. It is a different service provider, but the one chosen for this construction. So the cost is $533,928.
Is the cath lab up and running right now?
Dr. Brown.
Dr. Miller, it is not at this time. We're actually in the construction phase. We just finished with our fire inspection above ceiling. The cath lab got delayed from the tsunami, and it has arrived on California coast and will be shipped here. Cath lab installation date is, I think, 14 or 15 of October.
So we should be up and running before the end of the year?
Yes, sir.
Okay.
Mm-hmm.
Move to approve.
Do I hear a second? Any discussion? All in favor? Aye.
Aye.
All opposed?
Next is the Radiology Dynamics contract. This is for, to increase the radiologist coverage. It is the same group that we currently use. Currently, we have about 6 to 7 radiologists that are on call, but this extra amount is needed since we are now a trauma level 3 center. So it's needed to, these are the, requires a qualified radiologist must be available at specific times. And so this is just a amendment to the contract that's in effect of April 15, 2020.
This is an additional $477,000 per year.
That's correct.
All right, move to approve.
Do I hear a second? Any discussion? All in favor? Aye. All opposed?
The next contract is the Phillips Medical Group contract. This has to do with the MRI unit. We are currently in an agreement with Agility, which is the current provider, but the request was to go back to Phillips, who's actually the vendor, and they've seen some delays with using Agility and feel that this would help speed the process. So they're wanting to renew the contract with Phillips. The other piece here is that the machine is kind of at end of life, and they feel like this would be a not just a minuscule difference in the cost of $3,000 to $4,000 at this point to use Phillips instead of Agility, but also, again, since the machine is aging, have someone who directly created the machine. So I feel like this is a good move forward for everybody.
Is this a cutting edge machine? Is it something that we will have for a little bit, but yet it will be viable in using?
So,
provide highest quality of care.
Right. Dr. Brown.
Currently, Dr. Nettles, I believe that machine is around 10 years old. It was here when I got here, so I've been here 9 years. But what we felt like is if we go back to the OE, or the original manufacturer for that piece of equipment, it'll give us a better service. What normally happens is when you go to third party, they try to figure it out the first day or two, and then the third day they'll make a call, which delays the repairs on the piece of equipment. So by going back to the original manufacturer, when we call, if there's an issue, we call them and they come right out and start the repair process.
But will we need a new one soon? I'm just thinking.
Eventually, we will need a new one.
Okay.
What would you estimate? A year, 2 years?
Life expectancy is 7 years for a machine. So you figure if we're at 10, we probably have another good 3 years with it if it'll make that. But the one good thing is that we purchased the one in Bordeaux, which is a new machine, which will move not all of our outpatients away, but it will move most of our outpatients to that machine, which will give us some runway with the one currently here at the hospital. I hope that answers your question.
Do you anticipate most of the MRI procedures to be outpatient or inpatient?
Yes, sir.
Okay. So,
and we would service the inpatients with the one here at the hospital. But there will be some outpatients that will still visit the one here, depending on the patient. But we would like to get most of our outpatients to Bordeaux.
the majority of our patients will be imaged in a state-of-the-art
Yes.
MRI.
Mm-hmm.
Yeah. Thank you. Do you hear a motion?
So moved.
Thank you. All in favor? Aye. All opposed? Thank you.
The next contract is the Diagnostica Stago contract, which is just a capital purchase of a machine, a coagulation analyzer. This machine is 12 to 13 years old and just basically needs replacement, so it's a one-time cost.
Move to approve.
Do you hear a second? Thank you. Any discussion? All in favor? Aye.
Aye.
All opposed? Thank you.
Next contract is the Oracle Clinical Trial Management System software. And this I'll go into a little bit further explanation based on the cost structure here. But apparently, since we're scaling up in clinical trials, we need these systems that will be help with tracking patients through not just their life cycle of the study, but also the revenue in more real time. Currently, it's being tracked on an Excel spreadsheet. And this also integrates with Cerner, which is really important in what we're all moving to here in the next 82 days. And currently, we do have 3 studies that's going on now. We have 2 more that are scheduled for late fall, and then several more that'll come on tap by the year end of December. So in terms of the rates, there is a one-time implementation cost of $67,000. And depending on the trial, the number of trials, the bundle, that will reduce our cost as we have more trials. So the minute we move over to, let's say, 11 trials, that fee would drop from $99,750 to $79,800. So that's the reason you see the fee structure outlined. So that is probably an early next year opportunity to move down into the second tier, a lower cost structure. So hopefully I got all that right.
Are clinical trials revenue generating?
Yeah, so we'll have Dr. Fair.
The light's on. We're just short.
So to answer your question, it is revenue generating in terms of startup fees for the clinical trials. And there is some monies that do come in on the per patient fees, depending upon the study. Depends on how much revenue you can expect, whether it's an oncology trial, which is hard to accrue to, versus a hypertension trial, which is very easy to accrue to. So to answer your question, for the 3 clinical trials that we currently have open, I've invoiced about $82,000 in non-refundable fees for those 3 studies. So each study, I average about $27,000 to $30,000 of non-refundable fees.
Another element to this is that in future negotiation for clinical trials, there will be a line item for the CTMS system going forward. So you'll be offset the amount of that within the clinical trials.
Yeah. Did that answer your question? I know that was a lot. Okay.
Any other questions? And for these trial bundles, these are, I'd point out, they're one-time expenditures, they're not annual.
Correct.
Okay. Do I hear a motion for approval? Second?
Second.
All in favor? Aye. All opposed? Thank you.
The next on the agenda is the Oracle purchase, and basically this contract will incorporate lots of needed equipment and support for the Cerner implementation. So these are things like the computers, label makers, printers, et cetera, one-time big capital purchase that right now my understanding is that we've got equipment that are an average of 7 years old in our computers, some upwards of 10 years old, and we need these new items because of the new implementation. We did get not technical bids from other vendors, but they have priced this type of these items before with different vendors. I understand that there's not a wide difference in the actual cost, but part of the important piece here is that they will, Oracle will not only sell us the equipment, they will bring it and set it up here and then ultimately service the equipment. So with regard to similar costs, they felt like that this was the best option, considering again that we're 82 days away. There's also a 5-year warranty that covers this equipment as well. So all things being equal, that's the request, and that's the reason that no bids have been requested.
So this is a big item, but I think that the physicians in the room will agree that when a new EMR comes on board, it's really important that every computer in the house works the same way. And so it's a big expenditure, but it is an important part of adopting a new EMR. Other comments?
Can you clarify? So we initially voted on the EMR system. Were there any other items that ever came up for any additional hardware, or this is the first time we're dealing with hardware?
So we talked about hardware at the beginning just to prepare you for this big ask. This is the first big purchase that we have for equipment. There have been some smaller purchases that have fallen way under anything that would come to the board, just to get us ready for testing and things like that. So this is what we anticipated. Bruce earmarked some dollars aside very early on from the capital money that we had, and we were just kind of preparing you for this when we talked about it before.
So Bruce, is it fair to say the money's there? We're just designating it for this use.
It's actually a little bit less than what I had sort of earmarked for it. But like Melanie said, we have been buying small pieces, 2, 3 laptops or scanners as we're going through integrated testing. So it probably will be pretty close to the number that she and I picked a year ago. Thank you.
Move to approve.
Do I hear a second? Thank you. Any other discussion? If not, all in favor? All opposed? Thank you.
The next on the agenda is the Alliant Commercial Realty Services Agreement. This is a rental agreement to expand the space in the Metro Center location. The goal is to start moving some facilities to the Metro Center location. For instance, moving the radiology school, moving the School of Health Sciences, and then ultimately establishing a behavioral health program. Dr. Drummond, who's a psychiatrist, my bad, has gone out, visited the site, and so they're working to build out the space and to make that available to him there. They are also looking to move the food pharmacy upstairs, so just kind of grouping these areas together, where right now it seems like they're kind of more in different locations, so programmatically. So, Dr. Brown, anything to add on that? Is that fair representation? Okay. So again, this is right now we have a space of about 6,500 square feet. This would be adding 4,500 square feet approximately. And there are two options to the pay. And correct me if I'm wrong, Dr. Brown, but we didn't specify which option we would go with. These are the options on the table. So option one, which is the $11,163.03. The starting rate monthly, you get 2 months free rent after signing the contract, or option two, $7,941.08 starting monthly, 4 months of a 50% reduction of the rent after signing the contract. And this would be an addendum to the 2/28/27 contract. Any questions?
So how will you determine the options?
The board can determine the options, or Dr. Webb and I would determine the options.
Do you hear a motion that might include our leaving this decision to Dr. Webb?
Move to approve with the CEO and Dr. Brown determining which option they
Thank
prefer.
you. Harrison, thank you. Okay. Any discussion on that? All in favor? Aye. All opposed? Thank you.
Why did this contract come to us? It's pretty low.
This is a monthly rate you're looking at?
Which contract are we referring to? The one we were just talking about, or the next one?
Alliant commercial contract? Or are you talking about the upcoming contract?
The Alliant contract.
It's over $50,000 a year.
Okay.
Yeah. Okay. Last one.
Yes, last one, Pro Health Pharmacy Solution Service Agreement. This contract is basically a fee-sharing arrangement that will allow for us to potentially benefit from the current miss of revenue with specialty drugs. As part of this agreement, they will be building out space to accommodate this new specialty pharmacy, and this will be at Metro Center. There you can see the shared revenue agreements, year 1, 2, 3, 4, and 5, in terms of the different breakouts. And again, shared revenue. It looks like they will. Let's see here. Hold on just a second. They did receive multiple bids, and contract term is for 5 years.
So to be clear, this is a contract for our receiving money, revenue sharing from this new pharmacy, and does not require our approving any money to be put into it. Thank you. Any discussion? All in favor? Aye. All opposed? Thank you. And thank you, Ms. Smith. Next is hospital utilization report. Ms. Poole.
Good afternoon, everyone. So as part of our monthly utilization report, what I want to specifically talk about is our emergency room volume. We launched the No Wait ER back in March. And, oh, I'm not on there yet. No, that's after me. And at the time, we were averaging about 2,100 patients for the quarter. The first quarter then the fourth quarter of 24, we went up to 2,200. And after the first quarter of FY25, we should hit 2,300. So we've seen a steady increase in our ED utilization since the launch of the No Wait emergency room. Also, with our Metro employees, I did have a chance to speak with all Metro HR directors last week. They had their annual meeting to kind of kick off, what's that term? Annual enrollment, sorry, that's for the calendar year 25 medical benefits for Metro. And so it was great to be able to share with them the new locations, the opening of the Diagnostic Imaging Center, because what's really great about that, with it being our first freestanding imaging center, the HRA of Metro Insurance does not take as much money out from a freestanding center than it does from a hospital-based center. So a CT at the hospital is going to pull more money out of someone's HRA than a CT at the freestanding imaging center. So that's very important for Metro employees, just additional ways that they can save money. So our total Metro employees for Q3 was 501, for Q4 25 was 514, and for Q1 2025, the month hasn't ended, but we're already at 531. So we've been steadily also seeing an increase, and that's just Metro employees. It's not including NES, and then we will begin working on the state employees once we finalize everything with their insurance companies. Also, one of the things that you see in front of you, if you will take out your phones and put it to camera mode, and scan the QR code in front of you on the little acrylic signs that my team has provided on the tables. It brings you to a link tree that has a list of all of our social media. It actually starts with blog posts that if you click on it, it'll go straight to the different blog posts on our website. If you just scroll down, it says Connect with Us. And it has Facebook, Instagram, and YouTube. And it should have LinkedIn, I believe. And then you can connect also with Dr. Webb. We have him more heavy on Twitter and LinkedIn, just because that's where most of your thought leaders and politicians, or I shouldn't say Twitter, X, on that. And then also you can learn more about our health system, whether it's joining the NGH team, making an appointment, or even donating for the foundation. So everybody click on those and like and follow, and then that way, Chanel, when it comes to her pulling up the socials, she can be able to say, oh, Dr. Miller, I didn't see you liking our post. And then also there were a couple of, two other items that were brought up back in the end of, I believe, the May meeting that I just wanted to go back and address. So Janet tries to keep us all on track. One was Mr. Lester had requested that marketing and our government relations team work with federal agencies, I believe, to put the H signage on the interstate. So we did reach out to the state of Tennessee, and Nashville and Knoxville are the two large cities that have not developed a hospital sign system. It is up to the city to pay for that system. So only Chattanooga is the major city in Nashville that has opted to pay for a hospital sign system. However, we are working with Councilor Weiner and NDOT. We've requested to have the blue Nashville General Hospital signs at the end of the exit on 207, so it would be on Jefferson Street, and another one on 21st Avenue. There is a Metro General sign on Charlotte turning right on Dr. D.B. Todd, but just making sure they all say Nashville General Hospital to make sure it's consistent. So we'll provide another update at the next meeting on the movement of that. And then also in front of you is a list of events and days that we acknowledge here at the hospital. So toward the bottom are hospital events and then community events that we may participate in, broken down by each quarter for the fiscal year. So I'll be working with Janet to make sure that when we have those events, that you guys are added on any meeting requests. I just don't feel comfortable putting everybody's email all on one like we would send it house-wide, because there's no telling what emails you would get as board members. So we will work to coordinate that as well, because we will have some great things coming up. I know Jen's going to give her report, and I just appreciate the foundation. They've been really doing a lot of things for the staff here. Talent show today, hate I missed it, but apparently we've got some really great singers here. And I also want to give a shout out to Ashley Mancini, who heads up nursing education. My team, if you recall back in January, right before Heart Month, we had an event where we provided an AED to a local fraternity, and we used 2024 was going to be our Year of the Heart. So our annual brunch had a heart theme. We're the heart of the community. And then to continue that, we had an AED event for the Divine Nine, and Ashley and her team just did an incredible job. We had about 40 people up here. My team, Kaylin and Chanel and Simone, really put together a great event where there was about 40 people up here learning AED and CPR, life-saving things that they will take into the community. So, Ashley, appreciate you and your team.
Kathy,
Yes.
would you explain what the Divine Nine is?
The Divine Nine is a group of 9 fraternities and sororities that are the original HBCU fraternities and sororities. I'm getting it wrong. Somebody help me out. Phone a friend. Kaylin.
Let me stand. Can I borrow your mic? Okay. Testing, 1, 2, 3. Testing. Thank you, Kat. You did, you warmed up very, very well. The Divine Nine organizations are comprised of 9 sorority and fraternity organizations that help push scholarship, sisterhood, brotherhood, and service to the community. Many of our employees, as well as our executive leadership, are members of the Divine Nine, myself included, and some of our lovely board members as well. But it's a wonderful opportunity not only to spread education of why our individual organizations were founded, but also the mission and continue to do the work that our founders propelled. So if you want additional information, see us afterwards. Thank you.
That is the Divine Nine. Thank you, Kaylin.
The AED program, is that something that you're encouraging AEDs like in public buildings, school systems, that kind of thing?
Yes, we are. So what we see is there's a disparity in certain communities of color, and ensuring that they are not being left behind.
And are there funds available to purchase the equipment?
We have been allocating some of the resources I have within my division. So, yes.
It doesn't come up very often, but when it does, you really want to have people around and you want the equipment there.
Yes, most definitely. And
there was a high school in town where about 6 weeks ago that a middle school child had a full cardiac arrest, and it was nice that the school was prepared to handle that. And so it doesn't happen often, but boy, you really want it when it does.
Right, and the more people who know how to do basic life support and have access to the AEDs, the better. Definitely. Thank you for your support. Okay. Next, we have our Community Health Marketing Impact Update. Jerry Maynard.
My name is Jerry Maynard, and I serve for government relations regarding community health marketing. As you know, Misha Maynard is our president. She is out of town in Connecticut, could not be here. But we do have our business partner, Amanda, with us, who will be covering marketing and public relations. I'll be going over government relations and some community relations. And then after she's finished, we'll come back to answer any and all questions. You have before you our report. I just want to give highlights. I believe you have it in front of you as well, or part of your packet. And so I wanted to highlight some things both at the federal, state, and local level. At the federal level, beginning back in January all the way to May, we were working, or May or June, we were working with our delegation from Tennessee, with Senator Haggerty, Senator Blackburn, all of the congressional delegates, as well as Congressman Green, for the support of a designation for essential hospitals that would give them certain, not only designation of an essential hospital, but also certain benefits from that legislation. Unfortunately, you all have seen that with the election year, all of that came to a halt in about June, July, August, and we were not able to move that legislation forward. However, on a monthly basis, we were working with our delegation from Tennessee to try to get that moved forward and for them to pass it. Again, unfortunately, it did not go through, and it is stopped in its track. We meet with our AEH every week as part of our government relations team. On the state level, we've been working, and this is what I'm very excited about. We had the only bipartisan legislation to pass in the past legislative agenda and body, the only legislation that was bipartisan that passed that benefited Nashville and General Hospital specifically. In that legislation, we had sponsors by Senator Heidi Campbell and others that received unanimous votes that can lead between $10 to $20 million. I'll let Bruce speak more to that number, of $20 million of having state employees as well as their families and some retirees that can come to General Hospital and have waived their out-of-pocket and deductibles waived. That means that they can come here and they can receive service similar to that of Metro employees. We sponsored, when I say we, I sponsored that legislation back in 2008 for Metro employees. It took all this time to finally get the state employees passed. We were told it was impossible to do. We were told it would never happen. It happened. This is one of the most significant pieces of legislation for General Hospital because it can lead to so much revenue coming in, expanding our population and our population and our patient base. Not only have we been working on that, but after we got the legislation passed, our president, our CEO said, let's wait on marketing because we got to make sure that we have every I dotted and T crossed. One of the challenges that we had with Metro legislation, I have to take the blame since I took the credit, was we did not have buy-in from Blue Cross Blue Shield to waive those costs. Instead, what they did is they sent a bill or they sent a notice, a statement to the employees, and the employees did not have to pay it. And so rather than Blue Cross Blue Shield honor that, and then our benefits board from Metro, we worked tirelessly to get them to get Blue Cross Blue Shield to waive it and to not send those notices and statements of billing to our employees because they thought they had to pay those bills. We still have been bringing in under utilization, $4.5 million, $6 million, but it would have been much easier had we not had that happen. So working with Dr. Webb, working with Bruce and the other executive level, we stated, let's get it right. The worst thing we can do is market this out to employees. They come and then they receive bills. And they say, oh, I thought this was, you're waiving it, but now we see we have a bill. So we've been working with the state Human Resources. We've been working with the Department of Finance. We've been working with Blue Cross Blue Shield. I am happy to announce that after working with the executive leadership team, Dr. Webb, Bruce, Dr. Brown, Dr. Blakely, We have been working with Senator Heidi Campbell over the last 4 months diligently to get Blue Cross Blue Shield to state that they will work with us. And we received notification on yesterday that they will work with us to make sure that we do not have the same issues that we had with Blue Cross Blue Shield at the local level Metro. So that is a major win for us. We will continue to work diligently with them. But again, I'll let Bruce talk about the numbers, but this can be huge. This is a big deal for Metro and for Metro Nashville General Hospital, and we're proud of that. Next slide, please. We have also, if you see on there, I don't want to go through all of the community events that we had and working with all of the ribbon cutting, all of the community events that we had. But I do want to highlight one more, and that is that we recognize that oftentimes with our stakeholders at the state level, at the local level, they continue to hear from us about how important General Hospital is and how it's an essential institution of the city. We have a headwind that we face every day, and that is General Hospital is a liability to Metro and not an asset. And we have to face that every day in government relations, in marketing, and in public relations. It is an uphill battle, but we are taking that fight every day, and we're dealing with our stakeholders and our community. To that end, Bruce Siegel, who is the president of America's Essential Hospitals, came in for 3 events in order to talk about the national landscape regarding public hospitals, what General Hospital is doing, and to show that General Hospital is not only innovative, but they're leading the charge in innovative things that are going on with public hospitals and being effective in what we are doing. We are so happy to have Dr. Martin and Dr. Miller at that event. We also had 7 elected officials as well as community leaders. Of the 3 events, one was a dinner where we had with the president of SEIU. We also had the president of the Tennessee Hispanic Chamber of Commerce, Reverend Enoch Fuzz, along with Bruce Siegel, to talk about the importance of public hospitals and what they do in our city, but also nationwide. The next morning, we had a breakfast with over 75 pastors and community leaders and faith leaders, where, again, we had a roundtable discussion led by Dr. Webb and Bruce Siegel to talk about those issues so that we could get before our community and keep before them how important it is that we not only continue what we're doing, but also by having a new hospital, we can expand all of the programs that we're doing for effectiveness, for outcomes. Third, so those were the 3. The third one was when we had the elected officials, had those 3 events that were highly successful. We were able to capture it under Kathy's leadership. We have reels and assets that we're using now that we're editing and using as part of our marketing plan and strategy. And so that was another major item that we had. So working with the local officials, we have worked with them on a weekly basis. We contact our elected officials. We have contacted and met with every elected official on Metro Council level. Every new Metro Council person has come to General Hospital, done a tour, they have been briefed, and they've been told about the importance of a new hospital. So if you ever hear anything about how the new council members or any council members are not aware of what we're doing, that they do not support what we're doing, it is not true. We have met with every council member, and we have strong support among the Metro Council members for General Hospital and for a new hospital. I know because we talk to them every week. That's my report. Amanda?
Hey, it's great to be back with all of you. Following on what Jerry just shared, we really have taken a proactive media strategy this year and highlighting the fact that we are a leading essential hospital on both a local and national basis. And we really focus on innovation and high quality care for all. So to validate this positioning, we really focused on high impact content surrounding innovation, the No ADD community care team, clinical research, access and affordability through the Metro Incentive Program, as Jerry detailed, and then health equity and disparities through programs that address healthcare deserts, education, and some of the community activity. And I'm pleased to say that we, since the beginning of the year, have had more than 50 features on a national and local level. So for Q2 and Q3, 26 times we had high impact stories that hit both local business and healthcare trade publications, and we have 17 pieces of content in the works for the remainder of the year. We've been averaging a media hit every single week. The No Wait ED communication actually got 8 media hits and some great national attention. So as those new programs come out, we're really taking a proactive approach. Local events, we were able to get the media to the Bordeaux ribbon cutting and some interviews set up around the No Wait ED. And from an award standpoint, we promoted Dr. Brown, nominated him for Nashville Business Journal's C-Suite Awards, and I'm happy to say that he received honoree status and was selected to be on the front page of the Nashville Business Journal. Podcast, yes, that's awesome. And from a podcast standpoint, Dr. Webb and Dr. Blackledge have been featured on podcast interviews with Jerome Moore, which is a Deep Dish Conversations. We've gotten a podcast with Becker's and also one with Avenir Health. And from a speaking opportunity standpoint, Dr. Webb and other executive leadership team members have been invited to speak at both national and local events, including Becker's annual Becker's Revenue Cycle Conference and the 4th and 5th annual Social Determinants of Health and Health Equity Summit. In fact, I believe Dr. Fair will be speaking on Monday. We're really excited about that. And then Invest Nashville as well. We also initiated some co-marketing activity with RL Datix, which is a software organization that was implemented recently, as well as Canon Medical Partners. So taking advantage of those collaborations to bring attention to the hospital and to the greater community. So all in all, more good news is more important for hospitals who tend to just react to things. But with Kathy's leadership and with our team, we've been able to get some really great press and showcase some of the amazing things that are happening. And I think that it's gone very well thus far. So thank you.
Thank you for this long-awaited report. And I'm sure there will be some questions. One I have, Mr. Maynard, Blue Cross Blue Shield is willing to work with us. Have they indicated that they will do what we want, or is there work to be done there?
There's continued work to be done. The good thing is that we have senators and state representatives that support us, and they've been working directly with Blue Cross Blue Shield, but there is work to be done. I'm proud of, again, the ELT. We've been working hand in hand with Senator Heidi Campbell along with Blue Cross Blue Shield to get them to internally not send a bill to the state employees for payment that they are not responsible for paying.
Thank you.
Mr. Chairman, Mr. Maynard, first of all, thank you very much for being here today and giving us the report. Regarding the potential for a new hospital and the need for land for a new hospital, what counsel or advice would you give in terms of strategy for this board as individual members and as the board itself to support the efforts?
Well, first, I want to state that I always defer to the leadership of General Hospital. I talk with them. I don't want to talk about strategy in a public meeting or hearing, but I do talk to our president and our ELT about strategy on how we can move forward, what's good, what's not good, and then I take their lead. I'm an advisor and I'm a consultant, and so I try not to speak about that strategy in a public hearing.
Well, I understand that, but you are the political expert, and it would be helpful if you have had given advice or would continue to give advice that can be directed through Dr. Webb to the board about what we can do to be supportive as members of this board.
In fact, I would strongly support if we went into a strategy session or a special called meeting and we could talk about that where it's not a public hearing. Mr. Lesser, I would welcome the opportunity for all of us to sit down and talk with it not being in a public hearing about strategies and all the things that we talk about. And Mr. Lesser, as you know, every day we're talking about what can we do. It's just not appropriate to talk about it in a public hearing.
Understand, and I look forward to that meeting with you.
Thank you.
In a strategy session to have this kind of discussion.
Thank you.
And I hope, Mr. Chairman, that we can get that scheduled.
Mr. Chairman is listening. Thank you. Any other questions? Thank you for the report.
Me too. Thank you.
And Jen will present to us also from the awaited report from the foundation.
Good evening, Board. Can you go back one for me? Thank you. Good evening, Board. Some really great updates from the foundation. First of all, as you can see here on the slide, we've done some work with some of our messaging at Nashville General Hospital Foundation. So we've kept our mission very simple: to elevate, inspire, and nurture healthcare and health for all of Nashville. So kept it very, very simple. And you're going to be seeing more and more of our marketing out there. But today I want to talk a little bit about the state of the foundation. So I have met with many of you, and I'm going to continue to meet with all of you. And I've had continuous questions on, what's your priority? How can we help you? Where do we look like right now? So here it is. I'm giving it to you right now. So next slide. As I just mentioned before, our mission has changed. You can read that. I don't have to read all of it to you, but we want to keep it simple, but we want to keep it modern. You'll also notice that our logo has changed. We have different colors. So as we're talking about a new hospital and talking to donors, we want to make sure we have put our best foot forward. And part of that is kind of revamping our look and feel and branding at the foundation. Next slide. So, I've been asked about total revenue in past meetings, so I thought I'd just kind of put it out there for you from 23 to 24. And we do have 14 restricted funds. You see the number of donors have increased. And then our retention rate. So nationwide best practices for retention is 34%. So as you can see right now, we are under that. And then our current funding priorities we have is women's health, cancer care, access to care, basically the all-weather fund, as well as the patient medicine fund we've had in the past. But we're starting to focus a little bit more on transportation. We know there's a lot of no-shows at some of the clinics and to the hospital. And so we have been working with some of our medical partners, and they tell us that they don't have transportation. We have a wonderful and we have a beautiful van from Team Chad that was donated to us a few years ago. And so we are looking at very creative and innovative ways that we can utilize that a little bit more to make sure people go to their appointments or to their procedures. So one of the other things I want to highlight is the revenue. So as you can see, 23, 24, we're up a little bit. But guys, look at those numbers. We are in Nashville. Those numbers should be bigger. So what does that mean? That means I'm going to need some help from y'all. So next slide. So oh no, you're fine. So I kept this kind of simple, but as we all know, this is pretty complicated. But to be a connector. So one of the things that we've talked about before is how do we connect with our corporate community? We have not been very successful that in the past, but we're going to be changing it. So I look to you, and you'll hear from me quite often about being a connector for us. Let's find out who you know or who within your network or your spheres of influence can make that introduction. One of the things that the Foundation Board is working on right now is just like you just did, looking at our bylaws again. So in our bylaws, we want to make sure there's real transparency going on and there's real continuity going on between the Foundation Board and the Hospital Board. So we are looking for one member of the Hospital Board to also serve on the Foundation Board. So if you're interested, let me know. And then finally, attend events. So the foundation is coming up. As you heard today, we had the employee campaign that is wrapping up at the end of this week. We've had a lot of events with our employees. Would love to see not only our foundation board members, but also some of our hospital board members there. Today, we handed out ice cream. We had talent. It was wonderful. We're saying thank you to our employees. It didn't cost them anything, and it's just very, very goodwill. So having members there would be great. We have some other fundraising events going on. So it might seem simple, and I think in some respects it is, but the power that all of you hold is so incredibly important. Your spheres of influence, just your voice and being an ambassador for the foundation is a game changer for all of us. So I ask for your help with that. And then finally, in your packet, you'll see a report from the foundation. There's been a lot of great things going on. Just really quick, we had a donation from Team Chad for a brand new golf cart. So if you guys are not aware, we've had some issues with the parking garage and especially the elevators. So a golf cart was really needed because some of our patients obviously can't make it to the hospital. They were just not mobile. So the golf cart was not only donated by Team Chad. Thank you so much, Team Chad. They've been wonderful to us. We had the dedication a few weeks ago. We also, from the M. Stratton Foundation, Foster Foundation, they have given us funds for an art cart. It's a therapy that's by bedside. We've already had art therapy for about 40 patients. So you're going to be seeing that program grow, as well as a comfort cart. So a comfort cart will be probably in December. We'll start going on the floors, not only for patients, but also staff and for family members. So that's a really great addition. So a lot of good things going on with the foundation, but we can't do it alone. Jen can't be the lone wolf. I need your help. And then finally, in your packets, I have what's called the Leadership Giving Campaign. You probably have received something in the mail and some emails from me. A lot of times when we start a fiscal year, we start with an annual fund, and that starts with our leadership. And all of you in this room are leaders. So I ask you to give to that. We also have restricted funds. We have unrestricted funds. We have naming opportunities. If you're ever interested, please let me know about that. But I really am looking for 100% participation. Many of our donors ask. For grants, you have to have 100% participation to apply. So if you have any questions, please let me know, but know that I'll be calling and emailing you and sitting down and having conversations. Any questions?
Jen, thank you very much.
Thank you.
That's exciting, and I encourage everybody to participate. I certainly will.
We do need 100% participation. So I encourage everybody to look at the mail that you've gotten.
I would 100% agree with that. And I also think it's fair to remind people that, it'd be great if everybody could give a large contribution. Okay, understand that some people might not be able to, but anything to make sure we hit that 100% mark is very, very important for this board, for the foundation, and for the hospital. And I appreciate, Jen, your work and the fact that you have incorporated the phrase y'all.
One thing that Jen and I talked about was that if we really are going to raise a large amount of money, we probably need a designated project. And I think that she's going to be working with Dr. Webb on this, but we need to decide what our focus would be to go to donors in town on what we want to raise for, because they generally don't like to give to unrestricted causes.
Thank you for all of your comments, and look forward to reaching 100% quickly. Dr. Williams is not with us today. Do we have someone giving a quality report.
Good evening, everyone. And if you like the term y'all, I use it a lot. I moved here from New Orleans, and I'm extremely grateful for the warm welcome that many in this room have given me since I joined Nashville General. And special thanks to Dr. Webb and Jana for giving me the opportunity to come before you to share a general quality update on current state for Nashville General Hospital, but also to discuss some plans we have going forward around our high reliability organization goals and to promote general transparency across the organization and what current state looks like for quality and what we need to do to make things better. The quality report is in your meeting packet for reference, so I'm not going to go over all of the data, but I wanted to highlight is some of the things that as a new leader that I've been extremely impressed with around patient outcomes that I've been able to observe thus far. First and foremost, falls involving serious injury. It is very rare that you come across an organization that can go even 30 days without having a fall that doesn't involve a serious injury for our patients. I'm happy to say for Nashville General, we've gone over a year where we haven't had an incident where a patient, has incurred a fall. That's something to clap about. And involve a serious injury. We have now taken that a step further as an organization where we're tracking any fall, because the best that we can do to prevent a patient from falling, either during ambulation, out of the bed, we can prevent those falls with serious injury. So more work there for us as an organization. Another thing, we spoke a lot earlier around the need for having data analytics so that we can know how we're doing around general patient safety measures. And I'm happy to report as far as barcode medication administration, and this is where we are challenging our staff to make sure that they consistently scan meds so that we can positively identify that the right patient is getting the right med at the right time. And we are at 100% compliant in meeting that goal as an organization to ensure that we're scanning meds appropriately to identify our patients. Also, another thing to be proud of as an organization, we have gone several months without a single healthcare acquired infection for our patients, which is something you do not see every day. And I know many of you guys that have been here a long time ahead of me know the challenges that we have amongst our patient population with compliance with certain basic practices like hygiene and other things as a whole, managing chronic illnesses. It makes it very challenging to prevent healthcare acquired infections. But we have no healthcare acquired infections to report for the month of August, which is huge for our organization. And we have several metrics around healthcare acquired infections where we have exceeded more than 300 days without seeing those incidences. And this is validated data too as well. Another thing to celebrate is we've been the recipients of several regulatory visits from CMS. We've had the Louisiana Department of Health come in the hospital. And we also had a recent visit from OSHA to look at our safety practices for our staff. And I'm happy to report that we were able to clear any findings that were noted during those surveys. And knock on wood, we're hoping that Joint Commission shows up soon. We're in our survey window all the way through April of next year, and we're well prepared to meet those challenges with that survey as well. So that's the great things. I wanted to get those out of the way. Some areas of opportunity that we have, and this is not uncommon knowledge for us as an organization, hand hygiene. The number one thing we can do to increase patient safety, but also to protect our staff. We're running now at about 84% adherence as an organization, and this is because we have really increased the number of observations where we have secret shoppers that are trained to do these observations across the organization. So we are revamping a lot of education at the unit level, working with Meharry and our residents and other key care team members to ensure that we're doing appropriate hand hygiene always. Also, another opportunity that has been noted, and you'll see it in the meeting packet, is our substance bundle compliance. And we've been leveraging Cerner in particular and making sure we can build a lot of electronic cues to help alert our care team members of the timing around blood culture collection before we start antibiotics, things of that nature. So we hope to see that metric move to above our 75% goal, We have been very successful recently where our emergency department has implemented the bundle tool on paper. Sounds very antiquated, but it was the best that we could do right now before the Cerner implementation, where they're leveraging that checklist to be able to go through the proper steps to ensure that we're reducing complications around sepsis at the door. Also, to our responsiveness to patients from the call button. We've had some challenges where our call system has had some issues off and on, but we have leveraged our care team members where our nurses are strategically placed closer to where our patients' doors are at so they can respond to those call buttons a lot quicker, but also too in working with our medical staff too and others that enter the room so they know that when that call light is on, no one can pass that room without responding to what needs that patient might have. That's just a general overview of what current state looks like for us as an organization. Are there any questions?
I just want to applaud you on your report. That's one of the most thorough reports that I've had in this specific area. So as someone who've asked questions in the past on this, I really appreciate the depth, the focus, what you're doing well, and the areas of need, and as well as the benchmark. So I would love to hear at some point, obviously, to see all these in green. And I appreciate the benchmarking. And one of the questions I'd had in the past is how are we benchmarking, or is that knowledge available against other hospitals? So, as we go out, tell our story to lots of other people who may not have had the opportunity to visit the hospital. Quality of care, at least for someone who uses care but is not in the healthcare industry, to me, that's the most important thing, right? And I think these metrics, especially when we can get them on the right path, will be very important in telling that story. So, and also easier to raise money when you have a health institution that's moving the right way. So, again, thank you as someone who appreciates the thoroughness.
Oh, thank you for that. And we've also moved where many in the room participate in our 8:30 a.m. huddles, where we moved to being very focused on safety incidences as an organization, where we open up the table organization-wide that if anybody is aware of something that has happened that requires immediate action of any of us across the organization, that we're taking that extremely seriously. And moving towards also doing what we call deep dives, that when we do have safety incidents occur, that we're looking at those more in depth to see what were commonalities or trends we're noting so that we can address those more proactively instead of reactively too.
I also appreciate I read as well that executive leadership is doing rounding. And I think just that extra touch of having someone who comes in who has a higher level position to someone who's visiting the hospital can really make a difference as well. So for those of you who are in executive leadership doing that and just saying hello, I think makes a difference.
Okay, if there are no other questions, thank you.
Thank you so much for your report. Once again, welcome. And it doesn't sound like you had to adopt y'all to your vocabulary, which is, I appreciate it. All right. Medical staff report? Oh, yes, we do. Quality report. Do I hear? Okay. Been moved and seconded. Any discussion? All in favor? Aye, please. All opposed? We do not have Dr. Williams or Dr. Burley for medical staff reports. Do we? Dr. Katz? Okay, good. I see. I hear you. Thank you.
Turn it on? Looks like we're on. I see green. Thanks, guys. Matthew Katz, serving as interim chief medical officer. Thank you so much. I'm tremendously grateful for the opportunity to serve. The first item I have listed is the medical staff bylaws report. Very little to report here. This represents ongoing work. This is still top plate for the executive administrative team. There's been some shifting personnel, but we are well at work on this. More to follow. We have 2 months of credentials to review. The first is August, and the lion's share of these are teleradiologists and reappointments. I do want to bring the group's attention to a couple of highlights. In initial appointments for August, we have Armando Aguilera, oral and maxillofacial surgeon. And I can't believe I said all that correctly. And then Richard Zellman, cardiologist, interventionalist, structural disease specialist. At the bottom of this report, you will see that Dr. Nathan Kane, already privileged with us, general surgeon, is fully credentialed for robotics now. Now let's move to September. You'll see our new system, and we have photographs. Okay, I will draw your attention. I'll point out again, teleradiologists, reappointments, and there's a couple of folks that I will highlight here. Janet George, internist. Robin Jacobs, hematologist, oncologist. Followed by several teleradiologists, and then finally Ben Daner, urologist. Now I'll stop there. Are there any questions I can answer? Hearing none, I'll conclude. Thank you.
Thank you for your report, and welcome to the fold. Okay, ready for Bruce? Okay, I'm sorry. Do I hear a motion to approve? Second. All in favor? Aye. All opposed? Thank you. Mr. Nairmore.
All right, we've got May, June, July to cover, so I'll try to do it quickly and painlessly, Dr. Lesser. The month of May for the hospital was actually a very busy inpatient month for the hospital, almost 259 admissions. Budget was 218, so we beat that by about 19%. We also had pretty high observation admissions. I prefer real inpatient admissions, but even observation admissions are another admission into the hospital, and we do get paid for it. So pretty good volume in the hospital inpatient days. And then as you move down the line, you see ER visits, and I know we approved the ER contract earlier. But the ER volume in May was almost 2,500 visits. We're inching our way back with the no-wait ED, et cetera. The trend line is positive in the ER over the last few months since we started the no-wait ED. So almost 2,500 visits, about 4% above the budget, a couple of hundred visits higher than we had in April. Clinic visits this month, 4,548, pretty high, about 28% above the budget. And then as you move down the line there, you'll see a few things. Surgery and outpatient surgery numbers were right on budget for the month. The cardiac cath lab volumes did decline in May. We lost our interventional cardiologist at the end of May. He departed, so he was starting to wind down a bit the last half of that month. Deliveries were flat with last month, but still well behind budget, and year to date, they're very far behind where we ran last year for the same service line. So those are just sort of the basic statistics for the month of May. Then we get into the actual income statement. Inpatient revenues were behind budget. Patient days were behind budget, although admissions were very high. We're getting them out so quickly, the number of patient days to generate inpatient revenue is low. But in the finance world, we love that. Short stays mean less expense, and so we actually do better on the inpatient setting that way. Our outpatient revenue was well above budget. ER, observation, clinics, so that was significantly above budget. All in, our revenues gross were $27 million, which was slightly above the budget. What Dr. Blackledge and her revenue cycle team generated was roughly $5.4 million. Budget was 5.2, so we beat budget on net revenue by about $200,000. Then you get into the other revenues, which are very unpredictable. We budget usually each year based on the prior year. We had a good month for our other revenues, beat that by almost $2 million, which contributed to the month of total net revenues, 13.1 million, budget was 11, so a 2.1 million favorable variance there. On expenses, a little bit high, particularly you can see salaries and then supplies were pretty high. You know, we opened an imaging center. We're in the process of outfitting the Bordeaux location. So our supplies and pharmacy costs were pretty high in the month of May as we were doing setup. Still all in, we ended up with a loss of $540,000 for the month. Budget was we were supposed to lose $920,000. So we still beat budget, although we didn't particularly make money for the month. I do remind everybody to look all the way across to the year to date, and it still shows the hospital with a pretty healthy $5 million positive operating margin. And when we were budgeted to lose basically $5 million for that first 11 months. So good volume month, pretty high expenses, and a good net revenue month for our revenue cycle. And then the other revenues actually helped us make a budget for the month of May. So I'm happy to answer questions. I know this was approved at the Finance Committee, but questions? And if not, I'm going to move on to June. I think we approved them en masse at the last meeting, so I'll move on to the June financials. And this is obviously the last month of the fiscal year, the end of our fiscal year 24. Volume dropped off in June, and we have unaudited up there. Obviously, these will have to stand until our auditors arrive in a couple of weeks and get started. So for the month of June, volume did drop off broadly in the hospital and in the clinics. 168 admissions was 23% behind budget. Our observation admissions were a little above budget, but our patient days and census were very low on the inpatient side. In the ER, it actually dipped a little bit in June, 30-day versus 31-day month, but still dropped a little bit, even though we had the no-wait ED in place. ER admissions were 48, almost 27% behind what we budgeted. Our clinics were slightly above budget for the month, but that was a pretty low month. Just physician vacations in June clipped some of our volumes there. The OR, definitely the inpatient surgical cases were low. Outpatient was right on its number. And then I told you before, we lost our interventional cardiologist. So in June, what you see there is basically vascular and interventional radiology in the cath lab, no cardiac. Deliveries came up a little bit to 30, but still they're well behind budget. And for the year-to-date deliveries, you can see they're down about 19% from the prior year and 24% behind the budget. For the income statement, for June, inpatient revenue was $3 million short due to those very low admission and days. Our outpatient revenue was right on the budget, basically, mostly in observation, a little bit in ER and the clinic being above budget. So our net revenue for the month was close to budget, $80,000 shy, about 2%. And then in the other revenue areas, this is where we got a real benefit at the end of the year. The state of Tennessee had a program basically where they were trying to upgrade the Medicaid payments to hospitals across the state. They couldn't do it in the rate structure that late in the year, so they actually made a one-time payment through the Medicaid organizations, the TennCare MCOs. We received a little more than $2 million paid out by the three MCOs in the month of June. That's what boosted our other revenues so significantly for the month. So all in, for net revenues, we had a $15.3 million for the month. Budget was 13.1. And our expenses were a little higher than budget, about $700,000 higher. But for the month of June, which I would take any month, we had a net margin of almost $2.9 million. We were budgeted to make $1.3 million, but we beat that significantly. And for the year to date, we finished just a hair under $8 million positive operating margin, commendable. Some of that was one-time monies, but certainly a good end to the fiscal year 2024. And as like Dr. Webb always likes to say, we're in the black. I always take that with a grain of salt or two, because we still have, depend on significant support from the city for the mission that we provide to the uninsured on our campus. And so we do everything from a business standpoint to grow and produce margins in those insured areas of patient care for the hospital. So that's our June. Good finish to the year. Any questions? All right, so we'll move on to the first month of 2025 fiscal. Inpatient admissions bumped up again. They rebounded to 202, a little bit above budget, 17%, and our observation admissions were strong too. Patient days were actually above. Last year we ran 4.0 length of stay all year, so we dropped it in the budget down to 4.3 this year, and we pretty much hit the number on length of stay for the first month in July. Our ER visits went back up close to 2,500 for the month, well above budget and well above prior month. Clinic visits, almost 4,800 in the month of July, a really good month for the clinics. Surgery and outpatient surgery were both really strong in July. We really 70% and 40% above budget in those two areas. Unfortunately, the cath lab without a cardiac provider, the number is pretty low, just like it was in the June month. Deliveries were again very low, and that's the start of the stats for July. And then we move to the income statement for July quickly. Total revenue was right on budget. We were 0.1% below budget, $27.6 million of gross revenue. From that, Dr. Blackledge and her crew harvested $5.4 million, which was $250,000 favorable to budget. And then our other revenue areas, we were pretty close to the budget. We did accrue 1/3 of what we expect our certified public expenditure to be this year, and that helped bump that up about $650,000 for the month. So all in, our net revenues were about $700,000 better than budget. The challenge for us were expenses were very high in the starting month of July. We had the 5% annual increase for all employees. That is about a $275,000 increase that hit. It was budgeted, but it's a big change from June. And then just adding those new locations, the diagnostic center, the Bordeaux facility being full bore, and then the new pharmacy out at Metro. Those are all just areas where there's expense and not much revenue yet. So that's hitting our expenses. Also, we did an inventory at the end of June. And when we closed inventory, we had both cath lab and the laboratory that made bulk purchases in the month of July. We expense supplies when purchased. We don't put them into inventory and then decrement from that. So we expense them when they hit us. We'll probably have some benefit going forward with those bulk purchases. Anyway, all in for the month, our expenses were pretty high, $14.6 million. And that's what helped produce a loss in the month one of 2025 of $820,000. We were budgeted basically to break even in July. So a great finish to the fiscal year, a little sketchy start to the new fiscal year, but I think we're in decent shape. So any questions?
What do we do for cardiac cath now that the cath lab is down?
Well, the cath lab is down, and Dr. Miller, we don't actually have a provider currently. So, I mean, Dr. Brown and others can tell you, but until that cath lab is up, it's sort of hard to get Dr. Zellman and others to come on to, but we have to refer out. If we have a patient that needs catheterization, we refer out, and that's insured or not insured patients right now. We do. Any other questions?
Thank you, Bruce. In case you missed it, fiscal year net income budgeted minus 5.4, actual plus 5.8, and an $11 million variance from budget. And this is phenomenal.
Pretty good, huh?
I'd like to congratulate Dr. Webb and all of his team.
Heck yeah. Indeed.
Do I hear a motion for approval of these 3 months' financial reports? Second?
Thank you.
Okay, thank you. All in favor? Aye. Thank you. All opposed? And Dr. Webb?
Thank you, Mr. Vice Chair. I will say to my CFO that anytime I see black and not red, it's a good day. There's a lot of variation in how you get there when you're at the public hospital because one of your primary goals is to take care of those who cannot afford to pay. So you have a lot of sources that are public, supplemental funds, disproportionate share funds, federal dollars, and if you can manage that and get to a bottom line, you take credit for it. Thanks to the group. I want to just introduce to the full board. We introduced him at Finance Committee, Dr. Keith Stokes, who is here. He is the Executive Medical Director for the hospital, new. And on a sadder note, I want to just announce to you that Dr. Williams is out of town as to death in his family, and he's also transitioning out of the CMO role. And you met Dr. Katz a few moments ago, who indicated that he is interim CMO. So we'll be moving forward with these two gentlemen in the leadership roles. I think we're in good hands. I want to take a moment to acknowledge the cancer care program and the recent accreditation process. I'm going to ask Dr. Brown if he would share some information on how that went.
Okay, first I'd like to start by saying I'd like to recognize Faye Harnadahl. Could you stand, Faye? They have me as the cancer administrator, but I'm not the guy that runs the program. Faye is the one that actually puts the program together, keeps us, the providers and myself, on track. We've been here since 2015, and we did our first cancer survey in 2016. And we got, at that time, they had different levels like bronze, silver, and gold. And that year we got a silver, which meant we had 2 findings. The first year we had 2 out of the 7. Yeah, not this year. And so then finding, okay. Right. Okay. So, and then the go ahead, Faye.
We did not have any deficiencies. We didn't have any findings. We have 3 commendations. We missed it by 2. But we have 0 deficiencies.
Right. So that's why she's in charge of the program. And so the next survey we had, we went with no deficiencies, and at that time they deleted the gold, silver, and just gave you a go or no go. So Faye, again, had no deficiencies. And then this past summer, we had our another accreditation, and again, we had no findings. And the significant thing about this accreditation is that everyone that had a survey before us had a problem with the surgery note that they were found deficient on. And the surveyor was amazed that we were the only institution that was able to overcome that. I don't know what Faye and Dr. Asimbola and those guys did, but we were able to overcome that. And so we got, again, no deficiencies. So Faye's done a really great program of keeping us together and making sure that we stay on track and that we meet the requirements to have a stellar cancer program here at Nashville General.
We're able to meet all the surgical standards at 100%. And because of our accreditation status, we were given the Diamond Quality Partner designation by the Commission on Cancer, and that is through 2027. Dr. Webb tasked us to get a gold, but we gave him a diamond.
So just a little bit of information on the cancer program. It is the second oldest in the city, and it has been a stellar program, and the food pharmacy has contributed largely to the survivorship of our cancer patients. As a result of that, the food and nutrition that they receive so that they don't lose weight and are not able to continue their treatment, chemotherapy, or whatever the treatment is, we don't have food insecurity among our cancer patients. So that was recognized also in the last survey by our surveyors in the accreditation process. I want to make a quick point about the issue of the hospital as a liability. I think you heard that. So I just want to inform you that the hospital itself is not a liability. The liability is the commitment that was made to care for the indigent population. It's a good liability. It's like having a car. It's a liability, but it's what you use to transport yourself around. I think we need to put it into perspective that the hospital is just the method that you use to address the liability. It's not the liability itself. There's a commitment in the charter of the city that basically says we will care for the indigent, we will care for the young, and that's done through Medicaid. We will care for the elderly, that's done through Medicare. But the indigent, we care for, we don't turn anyone away, and we have a model of care here that we utilize to care for that population and to keep the costs down, and the food insecurity is one of those methods. It's very innovative, it's cost avoidance, and you won't find that being done in a lot of places. So I just want you to know that the liability is the fact that we agreed as taxpayers and as our government and leadership to care for that population. That's the liability. How do we address the liability? We utilize the services of the public hospital. So I have a list of items here that I was going to go over, but none of it is time sensitive. So you've been here over 2 hours now, and for the Finance Committee a little more. So I'm going to end my report, and Mr. Chair, Vice Chair, happy to answer any questions that anyone might have.
Dr. Webb, if I could just add a note to what you were just referencing. I would hate for us, in general, in terms of the kinds of image this hospital has, to never use publicly, I don't mean in regard to your definition, which I really appreciate. This is a huge asset. This hospital is a huge asset to this community, which is going to take us very far, I think, under Jen's leadership in the foundation. But I just want us to always play offense and not defense, because this is a huge asset in this community, and people need to be aware of that.
Yeah, I would agree. I agree with you 100%. My reference was to the frequent description of the hospital as being a liability. I certainly don't think it's a liability. It's certainly an asset. It's a great asset. I don't think that we could achieve the level of paying customers, which are in the majority, if we didn't provide high quality care, which means that our patients who cannot afford health care also receive that same care, because you're not going to be able to separate that. So we just provide high quality health care to everyone. It's an extreme asset for this city. And as far as the cost of health care, I don't think the city would be able to get the health care for the total population of indigent patients. We don't turn anyone away, and I don't think the city would be able to get that at a lower cost, no matter what method they use or what resource they use. So I think it's the best option. I'm a little biased.
Thank you, Dr. Webb. Reverend Stevenson, are you online? Do you have anything you'd like to say? Is he still with us? Okay. And as vice chair, I think I've said enough tonight. Somebody's got to be in charge of vice. And with that, the meeting is adjourned. Thank you for being here. Oh, I'm sorry.
I would just add, I thought there was a lot of really great information at this meeting today. And I appreciate staff and leadership and our consultant and everybody that gave us information today. This was very helpful. Thank you.
May I just add too that the clinical information that we get, sometimes we get caught in the numbers, and that's all important, the business side of it. But hearing the vigor of one of our amazing nurses and the work that she's done, and other clinical folks that have put in work, that's so important, to be able to bring everything together. So I agree. I think the energy is great, and let's continue to build on it.
Right. Thank you.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.